Heavy resistance training is safe and improves bone function and stature in postmenopausal women with low to very low bone mass. Novel early findings from lift motor trial. Abstract summary: the aim of the lift motor lifting intervention for training muscle and osteoporosis rehabilitation trial is to determine the safety and efficacy of brief bone-targeted high-intensity progressive resistance training with impact loading for postmenopausal women with low bone mass. Preliminary findings indicate lift motor program is safe and effective. Introduction: despite a lack of notable efficacy and exercise guidelines for osteoporosis, typically recommended moderate intensity exercises owing to a perceived risk of fracture from high intensity loading. Indeed, a safety concern alone have prevented the well-recognized preferential response of bone tissue to high-intensity loads from being applied to those who stand to benefit the most. To progress from the therapeutic stalemate, a challenge to conventional wisdom was required. Our goal was to examine the safety and efficacy of the hit and the impact loading for the risk factors of osteoporotic fracture in postmenopausal women with low to very low bone mass. Methods: participants have been randomized to either 8 months of twice weekly 30-minute supervised hit and impact loading in low density home-based exercise program of the same duration and dose. Testing at baseline and the follow-up was included in an anthropometry, bone, muscle, and fat mass, and functional performance. Results: 28 women results 28 women, 66.1 plus or minus 4.8 years, mean lumbar spine T-score negative 2.15 plus or minus 0.71 have completed the study. Hit and impact loading n equals 12. Improved height 0.4 plus or minus 0.2 centimeters versus negative 0.3 plus or minus 0.1 centimeters. P equals 0.003. Femoral neck bone mineral density, lumbar spine bone mineral density, and functional performance compared to controls. N equals 16. Compliance has been greater than 87%. There have been no injuries. Conclusions: brief supervised hit with impact loading is safe and effective exercise therapy for postmenopausal women with very low bone mass. The bone response to exercise is highly dependent on the nature of the applied mechanical loads. The most osteogenic activities and those that induce high magnitude strains at high rates or frequencies in bone. Under such conditions, only brief loading bouts are required to stimulate response. Such strains are typically induced by weight-bearing impact loading and high-intensity progressive resistance training, or otherwise known as HIIT or power training. Paradoxically, it is widely held that high-intensity exercises should not be attended by individuals with established osteoporosis, owing to the potential increased risk of fracture. In spite of the absence of documented evidence in the HIIT and/or impact loading will cause fractures in individuals with osteoporosis, this prevailing concern has led to the development of more conservative exercise recommendations for osteoporosis. For example, walking is frequently prescribed for osteoporosis despite the representing very low low-intensity loading and being largely ineffective for bone. In fact, all walking has been associated with an increased risk of falls in frail elderly, suggesting it is not an inclusive alternative. A recent consensus panel erred on the side of caution for older adults with vertebral osteoporosis, ultimately recommending a moderate intensity PRT protocol of 8 to 12 repetitions at 60 to 80% of one repetition maximum. Such resistance training intensity, however, is likely to confer modest benefit to bone at best, albeit increasing as loads increase. For many practitioners, the standard exercise prescription for osteoporosis is even more concerted, targeting falls and prevention rather than bone strengthening. To designate the therapeutic standard on the basis of hypothetical safety concern is counter to the principles of evidence-based on medicine. The scientific approach would be to test high-intensity exercise training in individuals with osteoporosis to determine true safety and efficacy. However, scientists have been However, scientists have been understandably reluctant to do so. As a consequence, the field has stagnated in recent years, with advances in exercise recommendations for osteoporosis constrained by a perceived risk of injury. Clearly, a leap of faith trial was necessary to reignite progress in the field, such as a study would require a concerned efforts to minimize risk, including close attention to exercise technique, gradual progressions, and supervision by suitably qualified clinical staff. The purpose of the LIFT project, the lifting intervention for training muscle and osteoporosis rehabilitation, was to conduct such a trial. More specifically, our aim was to determine the safety and efficacy of a brief bone-targeted HIIT plus weight-bearing impact training on the postmenopausal women with low to very low bone mass risk factors for osteotrophic fracture, including bone mineral density, lean mass, and physical function. While the data collection is not yet complete, our full sample, our significant and novel early findings warrant rapid demonstration. Method: study design. Lift motor study is a single blind randomized controlled exercise intervention trial. Eligible participants are block randomized to either 8 months of 30 minutes twice weekly supervised HIIT and weight-bearing impact loading or an unsupervised low-intensity home-based exercise program of a similar duration. Block randomization is based on the existence or absence of established 12-month exposure or lack of exposure. Osteoporosis medication ethical approval was obtained from the Griffin University Human Research Ethics Committee. Written and informed consent has been obtained from each volunteer. Participants: 100 postmenopausal women over 60 years of age with low bone mass, T-score less than -1.0 at hip and or spine, but otherwise in good general health, and being recruited from the community. The current report includes preliminary findings from the first group of participants who completed the study, N equals 28. Potential participants have been excluded if they had any of the following: lower limb joint surgery or injury, recent fracture or localized back pain less than 5 years, postmenopause malignancy, uncontrolled cardiovascular disease, cognitive impairment, recent X-ray or radiation treatment, contrain, indications for participating in heavy physical activity, conditions known to influence bone health, example, thyrotoxins or hyperparathyroidism, Paget's disease, renal disease, diabetes, or immobility, or taking drugs other than osteoporosis medication known to influence bone, example, prolonged use of corticosteroids, thyroxine, thioids, or anti-retroviral agents. Intervention exercise program. Intervention group activities included twice weekly 30-minute supervised HIIT and impact loading in small groups with a maximum of 8 participants per session. Bodyweight and low load exercise variants with a focus on controlled movement and undertaken for initial 4 weeks of training to ensure that participants are fully trained with correct lifting technique. For example, the participants are trained to avoid loading the spine in a flexed posture. Loading exercises are then introduced and intensity progressed so that all participants are able to comfortably perform the 4 exercises of the program: deadlift, squat, jumping, chin-ups, drop landings, and overhead press by the end of each month too. The 3 HIIT exercises, deadlift, squat, and overhead press, and then performed in 5 sets of 5 repetitions for the remainder of the intervention, progressively increasing weight to maintain an intensity of 80 to 85%, 1 repetition maximum. Impact loading is applied by jumping chain-ups and dropping landings. The participants start by reaching up to an overhead bar and gripping in an underhand narrow grip chin up position. The participants then jump as high as possible while simultaneously pulling themselves toward or above the bar using their arms. At the height of the jump, the bar is released so that participants drop to the floor. 5 sets of 5 repetitions of the action are performed for the duration of the intervention. Progression of the impact intensity is achieved by natural training and related increases in height of the jump and the chin up by raising the bar and by gradually increasing the intensity of the impact landing from shock absorbing flex lower limb position to a more stiff leg landing. The participants perform the 2 sets of 5 deadlifts at 50 to 75%, 1 repetition maximum to serve or warm-up required. The training intensity is fully supervised by an exercise scientist who is also a physiotherapist. Control exercise program. Control group activities include a very low load home-based exercise program primarily designed for the purposes of participant retention, with the potential to reduce the risk of falling, the latter of the ethical reasons to address the study of the care to individuals who may be at increased risk of fracture. The KINE regime was similarly comprised of 2 30-minute sessions per week, consisting of 10-minute walking warm-up, 4 stretches, and 4 low-resistance exercise: lunges, calf raises, standing forward raise, shrugs, with a focus on flexibility, lower limb muscle endurance, and balance, followed by a 5-minute warm-down walk. The intensity of the exercise is mildly increased by progressively adding hand weights to a maximum of of 3 kilograms and increasing repetitions. Outcome measures. Anthropometrics, whole body and regional measure of bone, muscle, and fat. Functional performance measures have been, performed at baseline and followed by a single investigator. Whole body, non-dominant femoral neck and lumbar spine, and fat and lean mass were attained using a dual energy X-ray absorptiometry and LS dual energy X-ray absorption scans with repositioning from this device, respectively. Physical performance was determined from both muscle strength testing and validated functional performance measures. Back extensor strength was measured isometrically and standing using a handheld dynamometer. Functional performance was measured using the standard protocols of timed up and go test, 5 times sit to stand test, and functional reach tests for all performed measures. The best performance of the 3 attempts was used for the analysis. Participant safety and compliance are monitored via training diaries with participants recording and any injuries or illness, delayed onset muscle soreness, 10-point visual analog scale, and any adverse events before every training session. The common participants were contacted either by telephone or email weekly to maintain investigator contact, minimize compliance, maximize compliance, and minimize attrition. 100% of the compliance is deemed to be the completion of the 70 sessions. Results. Participant characteristics. A total of 354 postmenopausal women have consented to participate in the lift motor trial to date. 72 individuals have met the inclusion criteria, completed a baseline testing, and have been block randomized to either HIT, impact, loading, n equals 36, or KINE, n equals 36. Of those, 28 women have completed their active trial period and are included in these preliminary findings. The LS and FN T-scores of women included in these preliminary findings have ranged from 0.6 to -3.1, with 13 and 15 women classified as osteoporotic and osteopenic, respectively. The main reasons for the participant exclusion are medical contraindications for the exercise, n equals 36, unable to attend training sessions, n equals 28, currently conducting the resistance or impact training, n equals 23, and not having osteopenia or osteoporosis, n equals 10. There are no differences in baseline participants' characteristics between HIT and KINE groups for anthropometric body composition measures or physical performance. Anthropometrics, the HIT and impact loading group have exhibited an increase in height compared to the loss in the KINE group. There is no significant between group differences in BMI or weight. Bone mineral density and body composition. The HIT and impact loading group have improved F and bone mineral density compared with the losses in the KINE group. An improvement in lean mass in the HIT and impact loading group and a loss in the KINE group approached significance for the between group comparison. There was no between group difference between fat mass, as both groups lost, however, within group improved. Group improvement reached significant for HIT and impact group. There are no significant between group differences in WB bone mineral density between HIT, impact loading, and CON groups. Physical performance. At follow-up, the HIT and impact loading group exhibited substantial gains in BES, significantly greater than CON, and FRT performance also improved in HIT. An improvement in TUGT in the HIT safety and compliance. No adverse events have been recorded as a result of either the HIT and impact group or CON exercise programs. One participant in the HIT and impact group missed a total of the 4 sessions due to injury unrelated to the training program. Of the 72 participants have completed the baseline testing, 4 participants, 2 in HIT and impact, and 2 in CON have withdrawn their participation as a result of unrelated illness. Compliance has been high for both HIT and CON programs, with no significant between-group difference. Discussion. The aim of the lift motor trial is to determine the safety and the efficacy of the 8-month brief bone-targeted HIT and impact loading exercise program for postmenopausal women with very low to low bone mass for bone mineral density, lean and fat mass, physical function. Early findings clearly indicate that HIT and impact exercise is not only safe but also sufficient to improve bone mass and to markedly improve physical function in this cohort. A highly novel observation in the net benefit of 0.7 centimeters in height in HIT and impact loading group, which reflects the evident reduction of the traditionally perceived increased risk of fracture from HIT for individuals with osteoporosis has presented its application for the management of the condition. Some prior evidence has been reported in HIT can be implemented safely in this population. A 12-week intervention of squat machines exercises that 3 times per week at high intensity, 4 sets, 3 to 5 repetition, 85% 1 repetition maximum postmenopausal women with low bone mass incurred no adverse events with a high compliance rate of 87%. In the current study, we have similarly observed no adverse events and have experienced the identical compliance rate of 87%, leading further support that perceived safety concern is not justified with HIT is performed in supervised and controlled environment. Numerous studies have demonstrated that PRT can improve lean and fat mass in postmenopausal women. The relationship is less clear for incidence of bone strength with number of moderate intensity PRT interventions, 8 to 12 repetition maximum, 67 to 80%, showing only modest benefits for bone. In light of what is known about the optimal adaptative stimulus for bone, it is possible to speculate that those modest improvements in bone mineral density were a result of inadequate load intensity. The study that applied the high-intensity training stimulus is not instructive then 12 weeks of exercise insufficient to observe changes in the bone. Our findings are the first to show the less conservative approach to exercise therapy, such as the lift more protocol, is both safe and effective for enhancing incidence of bone strength and fracture risk for postmenopausal women at increased risk of low trauma fracture. Furthermore, the benefits were achieved with only 2 30-minute training sessions per week, suggesting that lift motor program is highly efficient training approach that can easily be added to existing exercise exercise regime for the other body systems, example cardiovascular fitness. Increased back eccentric strength has been associated with reduced risk of vertebral fractures and a decreased thoracic cytosis. Marked improvements for BES in the hit and impact loading group coincide with the net benefit of stature of 7 millimeters for hit impact loading group compared to con group. Equally hit and impact group loading and bulk benefits in physical performance with significant improvements observed in the most functional tests compared with con. Together, the enhanced bone, lean and fat mass, physical function, and posture are likely to reduce risk of osteotrophic fracture and enhance the quality of life in this demographic. We acknowledge the preliminary nature of our findings, but note the strength of the data is reflected in early observation of strong statistical significance of treatment effects. Secondly, we recognize it will be important to account for confounding factors such as prior or concurrent physical activity and calcium consumption. Those data have been collected and will be controlled in the final analysis. Finally, our findings are applicable only to generally healthy postmenopausal women with low to very low bone mass. Another trial is underway to examine the effect of hit and impact loading in older men with low bone mass. In summary, a novel 8-month, twice weekly, 30-minute supervised hit impact loading exercise program was safe and effective for bone, lean, fat, physical function, and stature in postmenopausal women with low to very low bone mass. Despite the common misconception of increased risk of hit and impact loading in people with osteoporosis, the lift motor intervention has induced no adverse effects. Although preliminary findings suggest that the use of hit and impact loading is very time efficient, safe, and effective therapeutic option for postmenopausal women with low to very low bone mass. Musculoskeletal case study, osteoporosis. Geriatric case studies, the Montana
Geriatric.
Education Center's goal is to improve the health outcomes for older adults in rural Montana via increased knowledge of older adult care and treatment of health problems by health professionals. This case study is one of the series that presents a geriatric patient with health concerns. The case studies are written from the perspective of a variety of professionals, including nurses, pharmacists, social workers, and physical therapists. Each case is designed to provide a in-depth background and information from one of these disciplines. The interprofessional team perspectives have been approached to some degree, but are not comprehensive. It is the expectation that these case studies provide a good basis or starting point to be used in a classroom or training situation, in which an interprofessional team will come together to determine how this patient could be managed. Local resources and other team members should be utilized in determining a care plan for the patient. Focus should be placed in the patient outcomes with the patient and caregivers as members of the care team. Osteoporosis case study content. In this case study, for older women with osteoporosis, the case will present issues associated with drug therapy, diet, exercise, and complications, physio, physiosocial problems, and rehabilitation. The functional patient and any relevance to the actual patient is coincidence. Learning objectives. At the completion of the case study, the learner will be able to discuss the need of interdisciplinary approach to the care of this person with osteoporosis, describe the roles of the members of interprofessional team in the care of the person with osteoporosis, participate in the development and care plan, identifying possible issues, possible and possible solutions in the care of the person with osteoporosis. Please note, in the cart of normal laboratory test ranges, a glossary are available for download. Collaborative case study activity, setting 1, introduction and hospital record. Helen Davis lives with husband in a small city, has 2 grown children, has 2 stories, 2 step. History of present illness. Miss Davis presented to the clinic in December of 2010 with concerns about osteoporosis. She is becoming more astute and has already lost 1 inch in height over the last few years. She was 20 years old, postmenopausal, and has never been on hormone replacement therapy. She subsequently received a DEXA scan at the time and was placed on Fosamax 10 mg daily. Over the next year, this seemed to be working well for her, and she did not experience any side effects from the medication. In fall 2011, she sustained a fracture to her fourth metacarpal on her left hand that she suffered during a fall. She received another DEXA scan in late 2011 with no change. She seemed fairly stable and was only seen yearly after that time. During a repeat exam in 2013, DEXA scores continued to show progression, and she subsequently referred to an endocrinologist to eliminate secondary causes. After the thorough workup, no cause was found for her worsening osteoporosis. Thyroid studies were normal, as well as serum phosphorus, PTH, and urine calcium. A suggestion was made to switch to weekly Fosamax. However, this was not tolerated well, and she remains on Fosamax 10 mg QD. Family and social history. Mother died at age 40. Father died at age 57. Brother died with 79. Twin sister with ulcer, Proces, and depression. Patient is very active. She walks 1 to 2 miles a day. She stopped smoking 30 years ago and has an occasional drink. She also drinks a cup of coffee a day. She reports diarrhea and and has gas with dairy products, so avoids them. Current health status summary of current problems. Miss Davis Miss Davis is in a clinic today for follow-up visit for her osteoporosis. She reports increased pain in her back and ribs at times, for which she takes additional aspirin. She also reports feeling weak and at times with an occasional muscle cramps in her legs. She is 5'2" at 113 pounds.